Hi guys, welcome to the liver topic, and we'll be starting with hepatitis B. I could have started with interpretation of LFT also, but then it becomes very bland because we are not understanding the disease process, but we are randomly trying to remember what a lab report means. So I am going the vice versa way. That is, I will describe the disease process to you, and then subsequently we will understand how this disease process will affect the various variables that we tend to read in the form of LFT. The first and the foremost thing that I would like to show you here is an electron microscopic report of the blood film of a person who acquired hepatitis B. It could be due to sexual contact, blood transfusion, and the various modes of transmission will obviously be discussed subsequently. But in the era of integrated MCQs, they can give you a film like this and they can ask you to point towards the Dane particle. Now you very well know that the Dane particle would be an alternative term for the complete virion of the hepatitis B virus. So if you look at this green arrow that I've shown, which is, I would say, relatively a darker part of the slide, and it also looks like it is having some concentric lamellae present. This green arrow is the representation of the Dane particle. This on the outer side will be having the hepatitis B surface antigen, and inside would be the core antigen, which never comes in the blood. You very well know the fact that core antigen remains inside the hepatocytes. It is never demonstrated in the blood, but the antibody for it, yes, it definitely comes in the bloodstream as well. Now, what are these two more different arrows which are shown in the figure? So these are two different forms in which hepatitis B surface antigen is expressed. In fact, you should be aware of the fact that hepatitis B surface antigen can be expressed either in spherical format, I'll mention the sizes also, or it could be more in the form of, I would say, a tubular format as well. So the message is surface antigen can be expressed alone as well, or surface antigen plus the core antigen plus hepatitis B DNA, that's all tightly packed into one single area that I'll now mark before you. You can notice it looks like it's having a concentric lamellae present or concentric circle, because inside is the core antigen and then deep inside would be the hepatitis B DNA. So first and foremost, I've tried to explain to you the electron microscopy film of this virus, which would be from the microbiological domain being classified as belonging to the Hepa DNA viridae family. Now, the next query that they'll try to put up in the question would be that, is it a single-stranded virus? Is it a double-stranded virus? And before, even if I give a third option in the live class, suddenly guys blurt out with the answer, it's a double-stranded virus. So I want you to remember that it is partially single-stranded, partially double-stranded DNA virus. So lots of time we tend to blurt out an answer, but actually it's a partially single-stranded, partially double-stranded. And how is it written as? SS/DS. Now, this would be having a circular DNA, so a bit of microbiological component coming in. This would be 3.2 kb. And then no big deal. In the exam, they not only can expect you to interpret an electron microscopic image, but they can just give a line diagram or a schematic diagram of the hepatitis B virus and ask you to mark out the area. So what you're seeing in purple at the moment, this on the outside will be the hepatitis B surface antigen, which is the first antigen to appear in the blood. You see, when the virus starts replicating, first thing to come will be obviously hepatitis B DNA, but we're talking about antigen per se, because PCR is the best test for detection of hepatitis B DNA, but routinely PCR being done right after a history of sexual contact, blood transfusion is a little far-fetched in most of the countries. Most of the time the screening test that is done is surface antigen. So that's why I said first antigen to appear is surface antigen, though I also casually remarked this fact that actually even before the surface antigen, the virus is anyway is replicating. So PCR DNA will turn out to be positive in the early phase of disease as well. Now we move inside a little bit, and if I just point out to this red area, you can see a circular red area or the dots that are shown. This is per se the hepatitis B core antigen, which is never gonna be expressed in the bloodstream of the patient. When we go inside in pink, the arrow here is for pink. I'm just remarking the arrow here. This is hepatitis B DNA that I'm talking about, and we can perform a PCR and we can actually know how many international units of viral DNA per ml is blood, because we want to know the exact viral load as well. Then if I move slightly to the periphery, you will notice these green colored stars present here. These green color stars are for hepatitis B E antigen, which is a marker for replication. So if a patient is E antigen positive, it means the fact that the patient is highly infectious, not only to his sexual partner, but also to the doctor or nurse who's handling the sample. The total size of this virion will be approximately 42 nanometer. It's the range actually 40 to 45 nanometer is the size that is given for the Dane particle, but then I gave an average value of 42, and the inside part of it, the nucleocapsid component, this would be approximately the core antigen, the nucleocapsid, this would be approximately 27 nanometer. So a bit of routine data was explained here to you, both the interpretation of the electron microscopy as well as the line diagram of the virus you should be very clear about. At this junction, I also want to say that there are a couple of variants of this virus also. Like we know COVID virus, that would be having lots of variants, Delta, Delta plus. Similarly, they love to ask regarding the pre-core mutant component of or the variant of this virus, and also regarding the escape mutant. So we take them one by one. Let's first look at what do we mean by the word pre-core mutant, and this is relatively more common in eastern part of Europe, especially Russia and the former USSR group of countries like Ukraine, and then you can move to Armenia and stuff like that. So pre-core mutant, what it means is that in this one the E antigen is not expressed. Now, what's the importance? I mean, what's the big deal? Why are we so concerned about it? Because E antigen is a marker of the virus replication. So if this E antigen is not expressed, you will not be in a position to know whether the virus is replicating or not. You see, why it's important is when you are facing an enemy, like you see, I would not like to introduce politics here, but then I can say India is challenged by so many countries. So if we don't know what the neighbor of ours is doing, whether they are amassing tanks, whether they are putting up missiles in a particular area, I mean, you need to know what your enemy is doing. So similarly here, if you are not aware that the virus is replicating, you are calm, you are relaxed, you are thinking, okay, the virus is sitting comfortably, it's not causing any damage. So because the body is under impression that the virus is not replicating, therefore as a result of it, the damage caused by this virus is relatively more. So this is considered to be an aggressive variant of the virus as compared to the Indian virus per se. So this would be the detail for the pre-core mutant. Now let us compare this with the escape mutant. As the name suggests, escape mutant will be a public health problem in the community. Why? Because this can avoid the security system. You see, we are aware of the fact that the security system, that means the protective antibodies, antibody against the hepatitis B surface antigen. This guy is so smart that it has evolved over time to avoid neutralization with antibody against hepatitis B. As a result of it, even if you vaccinate the population, the vaccination will definitely contribute to development of protective antibody. The titers of antibody are also more than 10 international units. That's again a figure that they've asked. What is the protective antibody titer? I will write it down in the subsequent data or subsequent part of the slide, but at the moment I'm just saying verbally, more than 10 international units per ml. So person has been vaccinated, but is still getting infected. The person is vaccinated, but after a sexual exposure, or let me say IV drug abuse or percutaneous route, he is still getting infected. So the question arises, how? The point is the virus that he has developed, the virus infection that he has acquired after a sexual contact is of the escape mutant. So post vaccination, the person can still be having manifestations of hepatitis B, and therefore the word that will be used to describe the manifestations would be called as occult infection. As you can understand, the word occult here would mean that it's shocking, right? The person is vaccinated and still the vaccine has had not given any protection, though you have even checked the antibody titer as well. So these are the details initially that you should be knowing regarding, I would say, from the integrated perspective of hepatitis B virus. And now we're going to study regarding how this virus will be transmitted from one person to another. The first common route of transmission, or overall the most common route of transmission, will be answered as percutaneous exposure. And at this junction, I would like to also clarify before you that if the question says what is the commonest virus which is related to transfusion associated hepatitis, then your answer would be given as hepatitis B. Now these would look two very diametrically opposite statements when you read them for the first time, because on one hand I'm saying the most common route of spread is percutaneous, then I'm saying transfusion associated. See, there are two different aspects. One is how a virus can go from one route or one person to another. So sexual contact or sexual activity is one of the predominant activities in the world, so the virus can be transmitted. Second is when you consider a blood bag, we are obviously having checks in place, but in spite of that, in spite of the checks in place, there is a possibility that quality control might suffer, because of which the virus might still be transmitted across via a blood transfusion. So the message is, if you simply read a question, what is the number one cause of transfusion associated hepatitis. This is primarily because of quality control issues in the blood bank. Your answer would be given as hepatitis Bombay and not hepatitis Calcutta. But if the question is changed into an, I'm being repetitive here because this is a fact which is missed by a lot of guys on casual reading. If the question simply says what is the commonest route of transmission of hepatitis B, then it is not blood transfusion, it is percutaneous exposure. The second route of transmission can definitely be parenteral. Here I am gonna emphasize especially on IV drug users. You see, in earlier times, we were reading about quacks using hypodermic needles, which are being reused in clients. But now, because of increased awareness among people, and even the people, I would say, being very particular about when they go out for receiving any kind of a antibiotic shot or a vaccine shot, they would definitely ask the doctor that is this needle a fresh needle. So the incidence of, I would say, reuse of hypodermic needles has gone down, and it's mainly IV drug usage that will play an important role. And then quality control issues would anyway be related to blood transfusion. According to the rules of Government of India, testing aggressively has to be done, but then you see, if people have decided that they are not going to follow the rules, transmission can definitely occur. It is mandatory to test blood for at least 5. Obviously, it should be more than the 5 that I've written before you, but it's mandatory to test the blood at least for these 5. Like the blood bank will be charging some money from the patient. You see, blood per se cannot be charged. Blood is always against donation. Like if I need 1 unit of blood, my relative will have to donate the corresponding unit of blood. So I'll get 1 unit of blood for my elective surgery. The blood bank will still charge me 10,000 rupees in my hospital bill. That 10,000 rupees is not the cost of blood, which patients think like that, right? It is the cost of testing the blood, because after all, the blood has to be tested for hepatitis B, surface antigen when it comes to hepatitis B. And we also need to test the blood for HIV. So obviously we will be doing a 4th generation ELISA. So we will be able to pick up the HIV infection if the person is having HIV virus present in the blood. But then the problem is, if somebody has had a recent sexual contact and after 2 weeks of this sexual contact, he has come to the blood bank to donate blood, like it happened in Chennai. This lady had received blood transfusion at the time of delivery from a guy who had voluntarily donated blood at a blood camp after a few weeks of a sexual contact with a commercial sex worker who was HIV positive. So the guy was having the virus in his blood, but the virus was not detected because it was too early days of infection and the kit tended to miss this infection. You see, if somebody will get the infection on a particular day, let me say D0, it will take some time for the antibodies to develop in the blood. And if the person is tested initially, there is a high probability that the kit might miss the detection of the virus in the blood per se. Here I'm trying to bring about the concept of window period. You see, you would have done this multiple choice questions with respect to HIV, that what is the window period. So this varies according to the kit that is being used. For the 4th generation ELISA, the latest kit that is available for HIV, you can detect the infection as early as 3 weeks. With the older generation, when I was a student your age, I used to read about 6 weeks. So it's a range. In older MCQs, you will read window period of 6 weeks. With the current 4th generation ELISA, I said if somebody had sexual contact today, after 3 weeks, if he's tested, his ELISA will definitely turn out to be positive. And if I want a early detection, if I want to pick up the infection in the window period per se, I can even do a PCR. The point is, PCR facility is available or not available, that's a separate issue at a primary healthcare setting. But the point is that window period for HIV would be this particular time frame. So we will be running serum ELISA for HIV. But as I explained, if the patient is in the window period, there's a possibility that the infection will be missed. And this is what happened in India, in Chennai. A woman, after getting blood transfusion post-delivery, she developed HIV infection, and retrospectively it was found that this blood was infected primarily because it was tested, but still the blood bank got this infected blood because the missing of infection occurred because the testing occurred at the time when the patient was in the window period of the infection. When it comes to hepatitis C, for detection, ideally we should be doing a PCR. So obviously the cost will go up. Remember I told you about 10,000 rupees is the charges from a private blood bank most of the time. So to cut costs, they might actually be doing an anti-HCV by EIA. Now this is a very good method, but against the antibodies will take some time to appear. No, If somebody gets hepatitis C due to IV drug usage, he went to some cruise party and the guy was doing needle sharing and the needle is the same which even his drug peddler was using, and his drug peddler is hepatitis C positive, so this guy is also getting infected. As a result of it, antibodies are going to take some time to appear. So ideally, we should be testing with PCR, HCV, RNA, and you can very well see that more expensive tests that we're going to write, then the cost of testing will go up. And if the patient or I would say the client, as they prefer to call themselves, or customer as they prefer to call themselves instead of being referred as a patient, so they may not be ready to pay those charges. So the blood bank might be doing cost cutting. And when you do cost cutting, the chances of transmission of infection might dramatically increase, which is the reason why I explained to you that transfusion associated hepatitis can be seen commonly with hepatitis B, because if it is early days of infection, surface antigen usually appears in the range of about 1 to 12 weeks. That's a huge period. No, 1 to 12 weeks. I am saying you got infected today and the virus comes into the blood surface antigen within 1 to 12 weeks. So the point is, if somebody comes within the first 4 weeks of a sexual contact, blood transfusion, whatever, then subsequently there is a high probability that this person might be missed also. Then for syphilis, we will be doing a FTA-ABS testing. I agree to the fact that VDRL is also done, but VDRL is primarily done for neurosyphilis. CSF VDRL for neurosyphilis. Here we will be preferring to do for primary, secondary and latent syphilis FTA-ABS. And then when it comes to malaria, because falciparum is the one that is common in our country, the commonest type of malaria. So we will be doing 2 tests which are available. One is a dipstick. They love to ask about the dipstick method here, that is HRP2 dipstick. And instead of this, you can also run a peripheral smear, where you will be able to see 2 specific findings. One would be a banana-shaped gametocyte, and second would be multiple ring stage. In fact, these are very classical data that you have already been familiar from your microbiology. So I'm just repeating this data for you. Inside the red blood cells, so let me just symbolically represent this. In a peripheral smear, you will be able to see the malarial parasite. And if I just zoom it in, it will look like multiple ring stage, which is been shown here. In contrast, what happened in the NEET exam was, and I'm just using this opportunity to introduce this question, that my students reported that, sir, we were able to identify a parasite inside the RBC, but it was not having that classical multiple ring stage that you had highlighted. So I asked them to, just draw on a piece of paper, whatever they were saying. And they said, yes, sir, we could pick it up because it was having appearance of a cross. So you can very well understand our integrated MCQ here. Maltese cross appearance on a peripheral smear would be seen with the differential diagnosis of malaria, that is Babesia microti. But then one guy interjected in the chat and he said, sir, the question was not a direct one. It was a 2-step question. The question did not ask what is the parasite that is being seen. Rather, they asked that how would this be transmitted to the person. The answer in this case would be ticks. They asked the scientific name of it. That would be Ixodes capillaris. This is the vector which is responsible for transmission of Babesia microti. And it is no big deal that because they have asked this question in the previous years, they might ask it again, but not the same way. They might give you an image like this and say, prescribe the treatment for this patient. Now, just like you're comfortable with falciparum malaria, and we'll be using, I would say, the Chinese anti-malarial drugs for management, because anyway, quinine resistance is omnipresent in our country now. You know that from PSM. The question that I am putting to you, and I think I've given you 5-10 seconds, maybe more lag period for you to start, rewinding in your brain. What drug have I studied in pharmacology for management of Babesia microti? And when I'm writing it, I'm very sure all of you would have read about it. It's just that you should be able to recall this faster in the exam. So one of the drugs, 2 drugs which are given together, one of them is used in malaria and has also been discussed in management of pneumocystis jirovecii. I would specially request you at this junction to scroll down to the last part of this app, where I've discussed a couple of infections also, the important ones which are asked in the exam, which people think they know, but in the exam, I have usually seen people drawing a blank subsequently. So atovaquone and azithromycin, I'll just use the brand name here, azithral. So you can remember the facts. Babesia microti, a related fact which has been discussed here, on a peripheral smear would be having a Maltese cross appearance. Obviously, you know, Maltese cross appearance in the urine can be Fabry's disease, that we'll discuss separately in the kidney section. But Maltese cross on a peripheral smear, Babesia microti, the vector is Sixoides capillaris. The treatment would be combination of two drugs, that is atovaquone and azithromycin. And why we are discussing all this is because of the fact that testing of blood is of paramount importance, and because you have to test with expensive kits for so many infections, the blood bank might resort to cost cutting, or the technician who's employed may not be very skilled. As a result of it, there's a high probability that the person under your care might receive infected blood. In those circumstances, who will be held responsible? Not the technician, not the blood bank officer. It is you as a prescribing physician who will be held responsible. Yes, guys, we call this vicarious liability, that if under your care or under your, I would say, employment, if a technician or a junior person is making a mistake, the responsibility will not be fixed on the junior person, it would be fixed on you. So the reason in this discussion I have gone a little beyond the standard discussion for hepatitis B and especially highlighted on the aspects of blood transfusion is because you are preparing for a professional career, so you ought to be knowing regarding your professional responsibilities. Because if this problem falls on somebody, I mean, the person will obviously shrug his shoulders and say, sir, I'm not responsible, but the court doesn't listen to it. That's a merciless world out there, the real world out there, sir. Believe me, I mean, when you are in third, fourth year, everything looks rosy, you're gonna be a doctor, but it's not I would say a rosy picture from medical legal perspective. So you need to be strong on paper, you need to be strong on documentation, and be merciless on the blood bank. Always quality control is of paramount importance, because something goes wrong, responsibility is yours. Coming to the fourth method of transmission of hepatitis B, the case that can be given to you can be of a commercial sex worker. She is currently in her third trimester of pregnancy, and she's carrying a printout of a couple of reports that she saw that you are reading with lot of care. The report says that she's surface antigen positive as well as E antigen positive. And because she saw you as the young dashing doctor reading her reports with lot of interest, she asked you. She's an uneducated lady, commercial sex worker. She doesn't know what this report means, but she's asking you, sir, is there something wrong? So you told her, yes, ma'am, you have an infection, and there's a probability that you will be transmitting this infection to your baby. Now, she doesn't know what is hepatitis B and stuff like that, but she out of curiosity says, sir, I mean, okay, fine. What are the percentage of chances that my infection will be transmitted to my baby? You will tell her a figure that will definitely be, you see, even for a layman, substantially high. You informed her, ma'am, there are 90% chances that your child will suffer from the infection that you are carrying. And by listening to this, she says, can't you prevent this from happening, doctor? So the question to you guys at the moment is, we definitely can be having transmission during delivery of hepatitis B as well. In fact, it can be occurring during delivery, it can be occurring during pregnancy also. So the question then arises, because you see, after all, when the baby will come out of the birth passage, the baby will anyway be exposed to maternal secretions. Even if you do a cesarean section, no, even if you give an incision over the uterus, take out the baby, he still is coming out via the blood, which is of the mother, and the maternal secretions as well. So the eyes of the baby will still be exposed. There will still be conjunctival inoculation. Even if you do a cesarean section, the only thing is it will be controlled operation. So maybe the amount of exposure is lesser. So maybe you will reduce from 90% to 60, maybe to 70, maybe to 50%, but not make it 0. She's saying, sir, make it 0%. I don't want my baby to suffer. So you will tell her, no issues, we will make this happen. How? After the delivery of your baby, we will give to your child hepatitis B immunoglobulin. This would be given parentally to the child, with obviously taking care of the aspects related to anaphylaxis. So don't give it in the ward. Admit the baby in the nursery and then give hepatitis B immunoglobulin. And this should be done within 12 hours of delivery. And if you do this and provide passive immunity to the child, then you have saved this baby from getting the infection of the mother and suffering from damage to the liver and subsequently even an end-stage liver disease. Now another problem creeps up, which is that passive immunity lasts for a limited duration. Then this will be cleared up by the reticuloendothelial system. So for active immunity, you are also going to be giving hepatitis B vaccine to this child. This vaccine is made by DNA recombinant technology. You all know that. You would have taken the vaccine yourself. If not, do take it. The DNA recombinant technology vaccine will be given on day 0 of life. The next shot would be given at 6 weeks. And then subsequently, the third shot can be given at either, the word is either, 10 or 14 weeks. So how many shots are required? It's a total of 3 shots, and they would give protection to the baby over the next 15 years or so. What I have given here is a combo of passive plus active immunity. So every time they give you a report like this for a pregnant lady and they say what is the intervention to be done, your answer will be a combo of passive plus active immunity. The next method of transmission of this disease can be accidental needle stick injury. Let me say this is a young intern, is preparing for his PG entrance exam, and in the ward his senior told him, or the PG1 resident told him that, okay, do sampling of a fixed number of patients and after that you can go back to the library and you can study. So this guy, he has decided to take blood sample, and he knows the fact that the sample of the patient that is taking at the moment is surface antigen positive. So he has used double gloves. But after he has withdrawn the sample from the cubital fossa of the patient, he did something which he is always taught in his training never ever to do. That is recapping of the needle. You see, howsoever careful you are, there is a possibility that during the recapping of the needle can actually miss the cap and can accidentally prick the non-dominant hand index finger, and there would be a big drop of blood and possible chances of transmission as well. When I'm describing this, I can say that even in your OBGY postings, especially at night time, when you are suturing a episiotomy, you have to be careful, because when you are putting the suture in the subcutaneous tissue, or let me say on the vaginal mucosa or subsequently on the skin, the moment you are deploying the suture needle, it can hurt the index finger, and therefore chances of infection will be very much there. So for any time you are using a needle, you anyway have to be careful. This guy had not taken hepatitis B vaccine because he thought that he will take it subsequently, and today he has got a prick from a person whose file says surface antigen positive. So he freaked out and he's calling you. You are his senior, and he says, boss, what are the chances of transmission that I would be getting infection of this patient? Then the chances are huge, 30%. And on listening to this, he's even more nervous. He says, I don't want to die. So you told him, no, you don't worry, because hepatitis B virus is a mild virus. Majority of cases, there is a recovery. 90% cases of hepatitis B, even without any treatment, there is a recovery. But the point is, obviously, at that point of time, the 90% figure will not be very reassuring. So he's saying, boss, do something. So you would tell him, go to the casualty, inform the CMO, casualty medical officer in charge, or medical superintendent, some senior authority, and they will arrange for you hepatitis B immunoglobulin. Even if it is not in the hospital, they are supposed to identify centers where it is available round the clock, and this young doctor will then be given hepatitis B immunoglobulin. And if this is given intramuscularly to this doctor as early as possible, you see, I have given here guidelines based on that of internal medicine. There may be a possibility that the PSM person might give you a slightly different guideline, which might be a little more or little less than that. So you can follow the PSM for this. But I just want to say that try to do it as early as possible, because you don't want that the young doctor who's working with you develops an infection per se. The point is, passive immunity in this particular case would be sufficient, though I am saying this is for patients who have not taken the vaccine. If a person has taken the vaccine, then what you're supposed to do, then you're supposed to check the antibody titer. The antibody titer that will be checked will be antibody against the surface antigen. If it is more than 10 international units, then there is nothing to be done. I repeat the fact once again, if is adequately protected, the antibody titer is of values more than 10 international units, absolutely no problems. Point number 5 is valid for unvaccinated individuals. And once we know the common routes of transmission, I want to highlight once again, transfusion associated hepatitis, the number 1 cause would be answered as hepatitis B. But if he says what is the leading cause of development of chronic hepatitis, a slight change in the data. If he says what is the number 1 cause of chronic hepatitis, development of chronic liver disease from the virus perspective, right? Otherwise, alcohol will also cause chronic liver disease. So I'm saying virus induced chronic liver disease developing in a patient, and then there would be cirrhosis, there would be end stage liver disease, and then there would be requirement of orthoptic liver transplantation. So I want to highlight the fact that for all of these questions, orthoptic liver transplantation End-stage liver disease will necessitate orthoptic liver transplantation. The answer would be given as hepatitis C. You see, hepatitis C is not a cytopathic virus. It is just that it is the antibodies against the virus which keep on causing damage to the hepatocytes, and it's like a fire without smoke. With hepatitis C, it is like fire without the smoke. So you don't come to know that there is a fire simmering. To over a period of time, it causes damage to the liver, it causes cirrhosis, compensated, then decompensated, end-stage liver disease, hepatic encephalopathy, coagulopathy, and the complications of cirrhosis I have described subsequently. But this would need orthoptic liver transplantation. So the learning for you is hepatitis B virus is a weak virus. 90% cases will show recovery. I repeat the fact, 90% cases of hepatitis Bombay B, right? That's only for symbol purposes. B alphabet will show recovery, but for hepatitis C for China, hepatitis C, majority of cases, 80 to 90%, can progress to chronic hepatitis, subsequently have activation of stellate cells, and would be requiring a liver transplantation. We shall now be studying regarding the various antigens and the antibodies which are present. When it comes to the surface antigen, this is the first one to appear, but the one that will never appear will be the core antigen. So I'm gonna just use this opportunity to revise again some baseline data before I will create a table in which multiple parameters will be written, and then you would be expected to determine, is it acute hepatitis B, chronic hepatitis B, or is it a report infection? But for me to be in a position to explain that, we will have a look at some baseline information. You see, there would be total of 5 antigens that we'll study: surface antigen, core antigen, E antigen, X antigen, and hepatitis B DNA. Surface antigen is the first one to appear, usually appears within 1 to 12 weeks. That's a huge period. So average would be something like about 4 weeks or so. And when the surface antigen is appearing, subsequent to that, the liver enzymes will start getting deranged. And then subsequently, it is the serum bilirubin of the patient that will start rising. So jaundice takes time to appear. I want to highlight this fact at this junction. Once you have surface antigen coming up, then you have enzyme derangement, then you have jaundice appearing. In fact, jaundice in the sequence of events that I've explained to you is the last one to appear, but the first one to resolve. I repeat that again. Jaundice is last to appear in the temporal sequence of events. It's the virus replication, viral DNA coming up, then the surface antigen, then enzymes, and then serum bilirubin. Jaundice or icterus is the last one to appear and the first one to resolve. Biochemical recovery of enzymes will take maybe a couple of weeks, but jaundice usually will disappear within 1 to 1.5 months. When it comes to core antigen, I've already explained to you a couple of times. This would be related to being inside the hepatocytes, so never appears in the blood. And in the line diagram, I have also shown the location of the core antigen. I'll just show that slide once again. I mean, every time you study this virus, now always start from this, what I've just highlighted, because they love to incorporate these line diagrams of viruses. Now they can give it for any virus for that matter of fact, but then not only COVID-19, but even hepatitis B, which was a favorite of the examiners before COVID-19 came. So the line diagram is anyway important. Now, when it comes to the E antigen, the important aspect is this is a marker for replication. When I say replication, it means the fact that if a MCQ says that the blood sample of a patient is E antigen positive, you will consider it to be highly infectious to healthcare workers and to the sexual partner of this individual. When it comes to the X antigen, he will incorporate a bit of pathology because this is going to inhibit CD95, which is related to apoptosis. If you inhibit the apoptosis, cell will not die, and if a cell will not die, what will it do? Multiply. It will keep on having uncontrolled mitosis. So studies have shown that X antigen plays an important role by inhibiting apoptosis and development of a primary liver cancer, that is hepatocellular carcinoma. Again, I'm highlighting something which some people will say as controversy, but I have documentation from Harrison which says the fact that majority of cases of hepatitis B are responsible for development of liver cancer. In fact, the incidence of this cancer is more in developing countries as compared to developed countries, and in developing countries it is mainly hepatitis B that is more prominent. Both India and China, it's hepatitis B that's relatively more common as compared to hepatitis C. See all over, right? So majority of world population is concentrated in India and China. I mean, if we consider world population versus India and China together, majority of cases related to especially hepatocellular carcinoma are found in Southeast Asia. When it comes to hepatitis B DNA, the MCQ will deliberately write in a report on the basis of PCR because he wants to see that you are aware of the cutoff thresholds beyond which treatment is to be instituted. So if you read a report like this that says 2 into 10 raised to power 4, that's 20,000 international units of DNA per ml of blood, keep the focus on with doubling. Both things should be documented. It should be viral load plus doubling of SGPT. You see, just like in acute kidney injury, I've said doubling of serum creatinine, tripling of serum creatinine. In MI, I've talked about, troponin I showing a doubling, tripling, 5 times, 10 times elevation. So like we have a biomarker related to organ damage, the most specific test for liver damage, I'm saying verbally, I'll write it down. The most specific test for liver damage, alphabet L, is ALT. ALT again has a L. So most specific test for liver damage, ALT. Alternative name for ALT is SGPT. So if you read a question where the combination of the two is written, this means the fact that this patient is a candidate for treatment. The drugs that you will be using for treatment in this case can be either of the two, that is tenofovir. In some areas we are having resistance with anticoagulants, so tenofovir is what I've written first, though any of the two drugs can be used depending on the prevalence of drug resistance in the area. And tenofovir is also used in management of HIV. So anyway, in pharma you have done a question, drug which is useful for regular management of HIV as well as hepatitis B, that is if both are present in a patient, also distinct possibility in a country like ours, then tenofovir will be a common drug that would be used. In earlier times, I would not like you to note it down. In earlier times when I was a student your age, we used to read about injections, and we used to give these injections to the patient about 3 times per week. But you can very well understand that when you are giving injection, the acceptability will be lesser, compliance will be lesser, because patient might not be able to regularly come to the hospital for these injections. So the message is that alpha interferon is not used as of now for treatment of these patients. We use antivirals. Another reason we are preferring antivirals versus interferon is because interferon actually does not kill the virus directly. Interferon upgrades immunity. And when you upgrade the immunity booster component will contribute to death of the virus. So you are relying on indirect step. First pump up the immunity, then immunity kills. But here the drug will be directly acting on the virus per se. So antiviral drugs are preferred over interferon is the basic message. And once we are done with the antigens, we will now be focusing on antibodies that would be developing in these patients. The antibodies to be remembered by you would be antibody against the surface antigen, which is anyway the protective antibody. Then is antibody to the core antigen. And the third one would be antibody to the E antigen. And before I formulate a table before you, it's important to understand the importance. You see, antibody to surface antigen will develop even in an individual who has received a vaccine and also a person who has recovered from hepatitis B, because I told you in majority of cases recovery will occur on its own. But if he talks about antibody against the core antigen, he would like to talk about two aspects, IgM class of antibody and IgG class of antibody. If you read IgG class of antibody to the core antigen with surface antigen positivity, it means that the patient is having chronic hepatitis B, understandable, IgG chronic. But when you will read about IgM class of antibody with surface antigen, you will notice that in multiple choice questions, sometimes the answer is given as acute hepatitis B and sometimes the answer is given as gap period. What is the difference between gap period versus acute hepatitis B will become clear, and how would you in MCQ know what to answer? I mean, IgM class of antibody I said can be present in both the situations. So how would you decide in the MCQ whether you should answer gap period, whether you should answer acute hepatitis B will become clear in about a few minutes from now. So keep the focus on. Then is antibody against the E antigen. This highlights the fact that the replication rate of the virus is now reducing. So the infectivity of this person to doctor or nurse handling the blood sample or to the sexual partner of the patient will also be reduced. Now the information that we have learned for antigens and antibodies, will be deploying the same thing on a line diagram which has been asked in the exam for acute hepatitis B. So I'll just zoom it in for your convenience. You see, if he simply says what is the first thing to appear in the blood, then we very well know antigen wise, the word is antigen wise, it is hepatitis B surface antigen. But if you have a closer look at this diagram, you will also notice the fact that the gray marking that I've shown before you is for hepatitis B DNA. So actually the virus replication has already started, and we can definitely use PCR for early detection. But in majority of countries, PCR, because it is primarily expensive, it may not be deployed initially. So from the cost effective purposes, we usually use surface antigen for early detection of hepatitis B infection. Surface antigen can turn positive anytime between 1 to 12 weeks, usually around 4 weeks in majority of cases it will be found. In the exam, what he did was he put up an arrow on this particular dotted line and he said which antibody is present here. So the antibody in this case would be antibody against the core antigen. You see, I told you that core antigen itself never appears in the blood, but the antibody is very much there. Initially, the class of this antibody would be IgM class of antibody, though in the later part of the disease, this would get converted into immunoglobulin G class. And the reason I've shown a slight dip is because all antibodies over period of months and years show a progressive decline in their titers. The protective antibody which is present here and I've marked for you is antibody against the surface antigen. A query of lot of students is that why did you not mark the antibody for surface antigen for the dotted line? The point is, this is the protective antibody. So when this will appear, then the surface antigen will be showing a substantial dip. You can very well see the curve for surface antigen, which is the first curve in black, is showing a substantial fall, and that is when the protective antibody, this is heralding recovery of the patient. If a person gets a natural infection with hepatitis B, then this antibody can appear by itself without the use of any drugs. Recovery is the rule in hepatitis B. In 90% of cases, you don't need to give antiviral drugs. The antibody will appear on its own. The jaundice of the patient will resolve. Biochemical recovery will occur thanks to this protective antibody. So the red is representing the protection component, and this is coming in the picture when the levels of surface antigen have dramatically reduced and the hepatocyte damage is also reduced. I would now like to point out to this particular area, which I have now zoomed in for your convenience, where you can notice that surface antigen is on the verge of disappearing and the protective antibody titers are definitely rising. So there is some period in between at this particular junction when you are having only one thing which is present in the blood, that is IgM class of antibody to the core antigen. This that I am currently marking before you is called as gap period. This is itself a MCQ. Gap period would be characterized by presence of which antibody? It would be antibody against the core antigen of the IgM class, but surface antigen will not be present at this point of time, because you can see the way I have highlighted the gap period before you. The surface antigen is usually below the detection of threshold. I repeat once again, in the gap period, the surface antigen is below the detection threshold. So the only thing present here is the protective antibody. Once we have understood this, then we'll look at some more boxes which are shown in this diagram, and he can definitely put this up as a question to you guys in the actual exam. So the first box which is shown in orange, which is something in the range of about 4 to 8 weeks or in between where it is starting, this is when the E antigen will come up in the picture, and this would be marker of replication. However, subsequently the antibody against will also start coming, so the infectivity of the patient is reducing. So you can very well see the fact that as the protective antibody that is currently on the slide is mentioned, the moment the protective antibody is coming, the virus replication rate has also dramatically reduced and antibody against E antigen has appeared. As far as green is concerned, I just want you to remember that SGPT rises before the appearance of icterus. Clinically speaking, this is important because when the person comes to you with jaundice, because majority of patients will come to you when they're having jaundice. So when the person is coming to you with the development of jaundice, SGPT has already become elevated a couple of weeks prior to this. And you also can see from this diagram that jaundice will disappear, but the enzyme will still take some time to come back to normal. So the message is biochemical recovery will take time, but clinical recovery will occur earlier. In simple words, all you can remember is jaundice appears in last and is the first one to disappear. If you look at the temporal association or temporal sequence of the events, it was viral replication, hepatitis B DNA, surface antigen came up, E antigen came up, then was SGPT, then was jaundice. So let me just write it down before you so that you can remember this information in sequence also, and they can ask you to arrange in the correct order. It is surface antigen that is appearing from this diagram, Then in orange you can see it is the E antigen that is appearing, then the enzyme derangement is occurring, and then subsequently it is jaundice which is appearing in the patient. But if he says what is the which of these four will be the first one to disappear, it is jaundice which is last to appear and the first one to disappear. And you will also notice that in the x-axis the data that will be given will always be in weeks. So for acute hepatitis B, you will be having two spikes, one for surface antigen, another one for antibody against the surface antigen. The dotted representation is for the antibody for the core antigen. Though in the exam, just like it is given in Harrison, there is a possibility that he might give you another line diagram in which you will not see those sharp rise and sharp falls, but you will see curves which are relatively flattened. The second line diagram that I'm showing you here is for chronic hepatitis B. How to pick it up? One, you will notice that there will be not any sharp curves or bell-shaped curves that would be present in this particular representation. Or a easier way to remember this would be that the number of weeks here will be so many that it will spill over into years. Like 52 weeks is 1 year. So what I'm saying is the data is over a large number of years. That is why I'm going to call it chronic hepatitis B. I mean, that's one of the crude ways to identify it. And then apart from this, you can notice that in chronic hepatitis B, the surface antigen will remain detectable for long duration. Why? Because the protective antibody was not able to clear it off. So surface antigen that is persisting over years altogether, though I have also put in a dotted fashion to say that in some cases, it might show a progressive decline over a couple of months to years. But the point is because it's going to be detectable for long duration, so I'm thinking in terms of chronic. Another antibody which is always going to be related to chronic hepatitis B will be IgG class of antibody to the core antigen. Here I'm just signifying this is total measurement of antibody to core antigen, and initially it would be of IgM class. So this particular curve which was shown here is for the IgM class. The antibody came and it disappeared, but now the IgG class of antibody will persist for long duration. So if you get a question in which surface antigen is positive and antibody to core antigen of the IgG class is positive for a relatively long duration, which is spanning over years, I would say, then you can assume that we are talking about chronic hepatitis B, whereas the curve that I showed you initially for acute hepatitis B will be slightly different. So I would suggest you to, I mean, almost all the books, Harrison also, Robbins also, but it's always a good idea to just hand draw them like I have shown here before you, so that you are able to pinpoint with exact accuracy which antibody is appearing at which point of time. And usually the only mistake that I find here is mainly for the gap period, that people tend to casually answer surface antigen, antibody, surface antigen. The point is both the curves are on the lower side then. I mean, you can look here with respect to gap period, surface antigen is declining, the protective antibody is showing a substantial rise. So at this point of time, it is mainly IgM class of antibody, IgM class of antibody that would be detectable. Now, based on the information that I mentioned before you, let us assume a case of query viral hepatitis. When it comes to me, I don't know whether it is hepatitis A, hepatitis B, hepatitis C. So let's just look at how usually cases of viral hepatitis come to you. So today I'm having this young guy, he's about 20 years of age, and his primary complaint is that he has been feeling pukish for past few days. He says, doctor, I smoke on a regular basis, like he's a college student. So he says that the cigarette smoke, normally for smokers, cigarette smoke is very enticing. I mean, if they see somebody smoking, he will go to his friend and say, okay, buddy, let me just take 2 puffs also. But now he's saying, sir, cigarette is tasting horrible. And along with this, he says that the nausea is not only that when I'm eating, even the sight of food and even the smell of food, like he says that at festival time, maybe his mom cooked his favorite dish for him, but he says that I did not eat it and my mom was very angry that I especially cooked for you and you are saying that you don't want to eat it. In between, he has also had a couple of bouts of vomiting. So he thinks that he's having indigestion. He's having gastritis. He might have done some amount of self-medication as well, but the symptoms are persisting to the level that he has made a decision to come and see a doctor. He also says that he is also feeling febrile. So he took some tablets of paracetamol, and though the fever intermittently comes down, but once the effect of paracetamol is gone, the fever is again back to normal. And he also says that the right side of his tummy is hurting, or most people may not be so educated to actually put their hand on the right upper quadrant. So they just might say that I'm having abdominal pain. So I asked this guy to lie down while I'll be doing a general physical examination. And when I had a look at this patient's white of the eye, that is sclera, I did notice that there was icterus. And I immediately asked him that, did you not notice that your eyes were looking slightly yellowish? He says, yeah, maybe my mom was saying that my eyes look unhealthy. I mean, nobody would say the word icterus or jaundice primarily. So they'll say eyes were looking unhealthy. So that's one possibility. Or he might say that maybe when I was shaving in the morning, right, in front of the shaving mirror, when he saw his own image, he said my eyes looked a little unhealthy. And icterus or jaundice usually appears when serum bilirubin goes more than 2. In some books, it is mentioned 2.5 milligram percent. But yes, in pediatrics, in neonatology, you read about serum bilirubin more than 5 when the jaundice of a baby manifests and the face turns yellow, the skin of the face turns yellow. But in adults, elastin, which has a very high affinity for bilirubin, will contribute to the sclera of this patient turning yellow. And if you want to detect it early, you might even detect it below the tongue. The frenulum will also turn yellow. Especially in dark skinned patients, you can check out the frenulum because jaundice may not be so visible. So considering the jaundice component and the tummy pain, I put my hand on the right upper quadrant of this patient, and the moment I put my hand in the right upper quadrant, this guy literally jumped up. He says, "Doctor, easy, it hurts." I noticed that this guy was having a tender hepatomegaly. So the first thought process of mine when somebody comes to me with nausea for a couple of days, even the nausea to sight and even the smell of food, along with jaundice and tender hepatomegaly, it's a viral hepatitis, the first differential. And over and above this, I need to do some testing to identify which virus it is. And then especially if it turns out to be hepatitis B, I will have to do further testing with respect to the antigens and the antibodies that I explained. On clinical examination, I did notice that the liver span of this patient is increased. You know, the normal liver span will be in the range of about 12 to 15 centimeter, and hepatomegaly per se highlights this fact that this guy's body is responding to this infection. And it is always very important for you as a doctor to actually write down exact liver span in centimeter, whatever you were able to see. Why that is important is because suppose you decide to change the doctor, as you know, most patients would be doing doctor shopping. So when they change the doctor, they go to a different doctor. After 2 weeks, or let me say after 4 weeks, if he sees somebody else and at that point of time liver is not palpable, it means that prognosis is bad. If the liver is beginning to regress, it signifies the fact that this person is developing not cirrhosis, is developing or can go into fulminant hepatic failure. In patients of acute viral hepatitis, if the jaundice tends to worsen and the liver tends to regress, the word is regress in size, it signifies over the next couple of weeks that this person could be landing up into possibility of fulminant hepatic failure. I did check for pedal edema in this patient, which was not present. I also tried to look for findings of shifting dullness because I wanted to pick up free fluid in the abdomen. There was none. And then I also have a look around the umbilicus. There were no dilated veins, superficial veins of the anterior abdominal wall, and I could not pick up any caput medusae. Why I was looking for this was that this guy have chronic liver disease, and now he has developed the acute on chronic liver disease. But you can see the way I've written the data, I have tried to rule out all the common findings of chronic liver disease that occur in a patient, the decomposition part, none of these are present. So I can, at the moment, on the basis of the history of this guy, assume that this guy is having acute viral hepatitis. And why have I not written about the personal history of the patient is because most of the time in your government hospital OPD, you see there might be 2-3 patients, you know, there might be 3 doctors sitting and 3 different patients. And if you ask a young guy that did you went to a red light area or did you have sexual contact, he might actually not be comfortable giving you the history about his personal life in front of other people. That's one possibility. And even if you're having a isolated consultation, you have a separate chamber of your own, most people, you know, especially if they're young, they might think you might inform their parents, and they might actually not tell you about their personal aspects with respect to IV drug usage or snorting of drugs or casual sexual contact. So this history, I'll definitely ask the patient, but lots of time you may not get a correct answer from the patient because simply he does not trust you. So you have to ensure that the person tries to give you the correct history. Like in this particular case, let me say he did needle sharing and post that he has had this infection. But at the moment, considering the history, I have just written on the case file acute viral hepatitis, and now I will be doing a workup of this patient, considering the fact that it could be hepatitis A or hepatitis E also, primarily because of the fact that especially in India, you see fecal contamination incidence would be higher. So acute viral hepatitis A or E could also be present. Let's now look at how the LFT of this patient will show up. So serum bilirubin report, SGOT, SGPT will be considered. And then we'll also take into consideration the report of serum alkaline phosphatase. When you look at the serum bilirubin of this patient, you will notice that the values are elevated, total serum bilirubin, and even the unconjugated bilirubin values can be elevated because it's not getting conjugated properly in hepatocellular jaundice. Liver enzymes will definitely be deranged. In fact, liver enzymes can go sometimes up to 1000, though it's a little rare, but can go up to 1000, and mainly it is SGPT that will be deranged in this case. SGPT is present in the cytoplasm of the hepatocyte. So if there is a damage to the hepatocyte, like you study in pathology in acute viral hepatitis, ballooning of hepatocyte, and then they might get destroyed, they might get ruptured. So SGPT/ALT will start rising, though SGOT primarily is to be answered for alcoholic liver disease. At this moment, I want to highlight the fact that gamma GGT is a marker for alcoholism. Mark my words there. Heavy drinker and alcoholic hepatitis is not same, because lots of time alcoholic may not get converted into alcoholic hepatitis. So in a multiple choice question, if he says what is the marker for occult alcoholism, what I mean by occult is, you ask this guy, do you drink? He says no sir, but he goes to a shop and buys a quarter every day. Lots of construction workers do that, lots of poor people do that, lot of college students do that, but they'll not admit before you. So as a result of it, for occult alcoholism, where the person is not blurting out that I drink alcohol on a regular basis, gamma GGT. But if he says alcoholic hepatitis, that means definitive damage to the liver, then SGOT, SGPT ratios will definitely be increased. And in this guy, because there is no obstructive jaundice per se, so the SAP values may be normal or might show a slight elevation, especially in hepatitis A, but they will usually be less than 4 times elevation. You see in obstructive jaundice, in fact, I'll just put this on record here so that you can remember that if you get a LFT report in which serum bilirubin is elevated, mainly of the conjugated variety, and you notice the fact that SGOT, SGPT are normal or showing a mild elevation 1 to 2 times, but SAP is grossly elevated to more than 4x of normal, considering conjugated hyperbilirubinemia and 4x elevation of serum alkaline phosphatase, you have to think in terms of obstructive jaundice in a patient. So this report that I've written here is for obstructive jaundice, though the case that we're discussing is of hepatocellular jaundice. On the other hand, suppose in the exam he gives you a scenario where it is predominantly unconjugated hyperbilirubinemia and the remaining enzymes are normal or borderline elevated. If the report is predominantly unconjugated hyperbilirubinemia plus you find anemia in the patient and you find maybe splenomegaly in the patient, then you are thinking in terms of hemolytic jaundice. So my objective was just to sensitize you to the fact that when they give you a LFT report in the exam, they would expect you to pick up 4 times the elevation of serum alkaline phosphatase with conjugated hyperbil, obstructive jaundice. You can think in terms of from pediatrics, biliary atresia, adults it could be cholelithiasis, cancer head of pancreas, malignancies per se in geriatric age group contribute to obstructive jaundice. So interpretation of LFT report definitely matters, but it has to be taken with respect to the clinical domain which is given to you. And in our case, we are discussing a case of hepatocellular jaundice where predominantly ALT, which is the most specific. In fact, I'll just put that on record also. If the question simply says, what is the most specific liver function test? Then the answer should be given as ALT, the alternative name for SGPT. You can remember L alphabet coming up in ALT and LFT as well. Now, since the LFT of this patient shows a derangement in the fashion that I have highlighted before you, we will be performing an ultrasound next. And let's look at the ultrasound report of this patient. I will also be asking the radiologist to look for free fluid in the abdomen. So this is what the ultrasound report said. The liver span currently is increased. Thankfully is increased because on follow-up, there is a possibility that the liver span might show a reduction over 4 weeks, 6 weeks, 8 weeks. That implies the fact that the guy could be going into fulminant hepatic failure. Mark my words there. I did not say months. I did not say 6 months, 8 months. Then it's cirrhosis. If I say weeks, it's gonna be especially, under 8 weeks, I'm gonna call it a fulminant hepatic failure developing in a patient. I will also check for the echo texture and presence of free fluid in the abdomen. And at this juncture, it also gives me opportunity to mention again a radiological finding that you read, that is starry sky liver. You are aware of starry sky appearance on a CT head for neurocysticercosis, starry sky kidney post-streptococcal glomerulonephritis, starry sky appearance in a lymph node biopsy for Burkitt's lymphoma. I said that verbally because you read that in pathology, but a starry sky liver is you always have to think in terms of acute viral hepatitis in a patient. And now is my job to write certain tests for this patient. And even if he admits to a sexual contact, the first battery of tests that I'll write for this patient will not only be with respect to hepatitis B, but I also need to check he could be having hepatitis A also. So the other tests that I'll write for this patient would be IgM class of antibody to hepatitis A, though the leading cause of acute viral hepatitis in India and America is hepatitis E. So let's look at how do we diagnose hepatitis E as well, because if somebody comes to me with these complaints that I've just enumerated before you, just because he says that I had a sexual contact with somebody without, let me say, a condom, that does not mean that he has had hepatitis B. It is a possibility that maybe he after that date he went out to eat street food and he got infection from the poor quality food products that he was eating. So we should not be jumping on just because there's a casual sex mentioned in the history of the individual. There is a possibility that even fecal transmission may be present, and that is why I have decided to keep all the options open. And this is the first battery of tests that I'll be writing for this patient from the serological perspective, that is antibody against hepatitis A as well as antibody to the core antigen. The next test I'll be writing would be antibody to the C virus, because lots of time hepatitis C can be developing after IV drug usage. And now we will create a table that will help us identify not only hepatitis A, not only hepatitis B, not only hepatitis C, but will also help us pick up non-A, non-B, non-C. Non-A, non-B, non-C would mean it could be hepatitis D or E. And because D occurs with B, if B is negative, then E definitely is going to be the diagnosis of the patient. So first possibility of the report is his surface antigen turns out to be positive. The markers for hepatitis A and C are negative, and there is IgM class of antibody to the core antigen. If you find these two things written together, it means that this chap is suffering from acute hepatitis B. So when he comes back to me with this workup, I will write acute hepatitis B on this patient's file. However, let's just change the perspective now. The markers for B and C are absent, but IgM class of antibody to hepatitis A is positive. Then though this is more common with respect to pediatric age group, adults, you see, in India, subclinical infections develop. So it is very unlikely to have acute hepatitis A in a 20-year-old guy, because the water that we drink, right, and the street food that we guys eat, that's always having some kind of subclinical infection. So most of the time hepatitis A occurs in pediatric age group. Adults, due to repeated subclinical exposures, develop sufficient immunity. That's some words about what Americans say as Indians have a very good immunity. That's because they can eat golgappa and they can eat street food and stuff like that. Is because we usually end up with I would say a gradual onset repeated low grade infection. So the subclinical infections result in Indians having at least a better GI immunity per se. Now let's look at the next possibility. In the patient, all the markers are negative except for anti-HCV. This is again a very unlikely possibility, considering that hepatitis C mainly is chronic, but because this is a academic discussion, so I'm just taking the liberty of mentioning that this person could be having acute hepatitis C as well. Now, once I've done the following test, then I can also mention that if all these tests turn out to be negative, in fact, that was the main agenda that I want to highlight, because this is a line in Harrison that is written that if all of these will turn out to be negative, that's the last parameters that I've written, then you will write that on the case file as non-A, non-B and non-C. And that implies basically hepatitis E infection. Why? Because D occurs alone. D alone does not cause a damage. You either have a co-infection, you have a super infection. You know that from pathology. So D would be present with B only. If B markers are negative, then D alone will not cause a problem. So I will think in terms of hepatitis E. The last part of this table, though I don't want you to note down, is that there is a possibility that person could be having acute hepatitis B as well as acute hepatitis A as well. I mean, two infections could be coming up together in a patient as well. So this is anyway a rare possibility of having a dual infection. So I just wanted you to be sensitized, but this is the routine battery of tests that would be done. And from the exam perspective, even if you don't remember all the interpretations, I just want you to remember that you don't straight away write all the tests for hepatitis B in any person who, even if says that he had unprotected sexual exposure. You have to consider other hepatotrophic viruses as well. So the initial battery of tests will be surface antigen, IgM class class of antibody to the core antigen, not IgG, IgM class of antibody, IgM class of antibody to A virus as well as the C virus. And if majority of them are turning out to be, in fact, all of them are turning out to be negative, then it could be hepatitis E in the patient as well. And the number one cause of acute viral hepatitis in India is hepatitis E. Now, considering the fact that my patient is having surface antigen positive as well as IgM class of antibody to the core antigen positive, so my diagnosis of this patient, who initially refused that he had done any kind of IV drug usage or sexual contact, but now once the reports are turning up, he is coming up with the real facts before me, and he did admit to the fact that he had unprotected sexual exposure at a red light area and he did drugs also. So I've written on the case file acute hepatitis B. In these patients, there is no need for prescribing any antivirals because recovery is the rule. So I will assure this guy that your body will respond to this challenge by production of a protective antibody by the name of antibody against surface antigen, and you will recover from the infection. At this moment, because there's a predominant nausea component present, so I will tell this guy to stop smoking for a couple of days because that will anyway worsen the nausea component, and I can give etopride or muzapride to these patients. Along with this, if vomiting is a predominant complaint, you can be using domperidone and metoclopramide. If there's some component of dehydration present in this patient post vomiting, then you can admit this person and give him normal saline. If there's a concomitant hypoglycemia because he has not eaten for a couple of days, and even if when he's trying to eat, even if he's trying to, eat one of his favorite food item, he's puking all the time. So there might be hypoglycemia for which 10% dextrose would be given. The message is in acute hepatitis B, in 90% of the cases, there is no cause of any worry, and there would be a development of spontaneous recovery. In fact, I want to say that majority of cases are lost to follow. I mean, in majority of cases, when you call them for follow-up, even if your receptionist will make a call to the residence of this person or to the personal number of this person saying the doctor is calling for a follow-up, most patients will refuse to come. Why? Because there are no complaints. Jaundice has disappeared. Biochemical recovery will anyway occur in these patients. So most patients are lost to follow-up and you never get to see them again. But in chronic hepatitis B, because it's going to contribute to development of cirrhosis, I would definitely like to intervene and I would like to give antivirals to the patient. So judicious use of antivirals is to be done. So let us now study how would we be identifying chronic hepatitis B. So I will be making another table before you where I'll be putting up multiple parameters, and you need to listen to the permutation combinations carefully, because in the exam there are two ways he can ask you. One, he can just give you a broad diagnosis of acute viral hepatitis and then ask you to pick up the etiological agent A versus B versus C versus non-A, non-B, non-C as I explained to you, or it could be specific against hepatitis B. So the battery of tests that I'll be writing for this patient will be minimum at least 4. That is 2 antibodies against the surface antigen and the core antigen, and then would be 2 antigens, surface and the E antigen. I can also write antibody for the E antigen, but to make the discussion simple and straightforward, I am taking into consideration the ones that really matter. So possibility number 1 is anyway the initial report of the patient that he turned surface antigen positive, but in the early weeks of infection, security system has not appeared. At the moment, IgM class of antibody to core antigen is present and the virus is actively replicating. So my diagnosis of this guy would be that he's having acute Hep B, and because E antigen is positive, I will anyway make a note of that saying that the person is having high infectivity and the sample of this patient should be handled very carefully by my office. Now let's look at possibility number 2 in the same patient. This patient, couple of months from now, the security system has not appeared and the class of antibody has changed over to IgG. That means the fact that there is no recovery, because recovery will occur when the surface antigen will disappear and antibody against the surface antigen will appear. But here the security system is missing in action. As a result of it, the IgG class of antibody and surface antigen combination together is telling me that this is chronic hepatitis B, and see, the virus is making fun of the immune system by still replicating. Though I used a casual word, the immune system is being challenged here because the virus is still replicating. No, because the security system at the moment is sleeping. So this chap is having chronic hepatitis B, and therefore I told this guy, sir, I will put you on some medication. It could be in the form of injections like in earlier times or antiviral drugs. So patient is saying, okay, sir, fine, I'm ready for the medication. And how would I come to know that I've responded to your treatment? So I will tell him that when I start giving you these drugs, after a couple of weeks and months, depending upon whether interferon is being used or we are using once a day tenofovir for 48 weeks, if the person will be compliant with the medication, this is what will happen in the body. The drugs will actually kill the virus, so surface antigen will disappear, and the immune system will now get an opportunity, because if the viral load is lesser, the immune system will get an opportunity, because earlier the immune system was overwhelmed. Earlier, the immune system was overwhelmed by the high viral load. Now, when you decrease the viral load, the immune system will start responding. So, the security system will gradually start appearing. The class of antibody, IgG class, would still be present. But because now you have killed the virus, the replication is also not occurring. So, E antigen will turn negative. So, I want you to compare the second report that I've just marked before you of chronic hepatitis B with the one where I've shown the virus is dying. How did I know that? Because the surface antigen is turning out to be negative, the E antigen is turning out to be negative. So if this is the report that you are given in the exam, in fact, they can give you two reports and can ask you what would you interpret of this. Then the second report tells you that there is a recovery in the patient. In fact, you need to look at this from the perspective that two things that were telling me that the virus is live and kicking, those are turning out to be negative thanks to the compliance of the patient and the medication that I prescribed. However, suppose it gives you a permutation combination in which only the security system will be present. This would be piece of cake for you, because if there's only security system present in the picture, then this would be people like you and me who have taken the vaccine, or a child who has been given vaccination as per the national immunization schedule. But suppose it gives you a question in which the only antibody present is IgM class of antibody to the core antigen and everything else is negative. Only IgM class of antibody. Remember I taught you gap period? So most of the time when you interpret these tables, it's going to be very simple and straightforward, especially for the second last two entries that are made, because if there's a single antibody present, security system, vaccinated, IgM class of antibody around mean, that implies that there's a gap period present in the person. Now let's look at another permutation combination, which initially will look intimidating for you because there is no surface antigen. But still in the patient there is IgG class of antibody. You see, earlier I was teaching you that if there is surface antigen positive, cast a look at the second entry of the table and then at the last entry that I'm making on the table before you. You see, earlier I said surface antigen positive plus IgG class of antibody to the core antigen, but here it is only IgG class of antibody. This can be having two possibilities. One would be, and this is what you will answer in the exam, this can either be a low level carrier. That would be, because there are two interpretations here, so I'm writing them down in decreasing order of importance. One would be low level carrier, or it could be a remote infection. He could have had infection long time back, so now the surface antigen has disappeared below the threshold of detection. You remember the curves that I made before you, especially for chronic version. I'll just go back and show you this curve that I had drawn, and you can see that surface antigen was showing a declining trend. So it might actually go below the level of threshold, because of which I have mentioned in this particular table the description of remote infection / low level carrier, primarily because the surface antigen has gradually disappeared in the patient. So these are various permutation combinations in the table which are to be remembered. Let's make a summary of these also, because ultimately that summary will come in handy. So at this moment, even if you're using printed notes, I would suggest you still to strongly recommend you at this moment to remember the following aspects and note with me. If the question simply says antibody to the surface antigen present and it gives you an antibody titer also, cool. I mean, this would be the best way to identify the fact that the individual is protected, he is vaccinated. There are two ways again. One could be that he has taken vaccine or he has had a natural recovery. I mean, that's again a possibility. No, he got infected, made a natural recovery. Then is antibody to the core antigen. And various permutation combinations for the same have already been discussed. So I'm going to discuss both the combinations with you. If you get IgM class of antibody described and this is given alone in a MCQ, I hope it's very clear. If it is given alone in a MCQ, it's gonna be gap period. If it is combination with hepatitis B surface antigen, as I mentioned earlier, it is acute hepatitis B. For acute hepatitis B, you need two things: surface antigen plus IgM class of antibody. Alone, don't answer acute hepatitis B. That's the commonest mistake that people make. So I've sensitized you enough for that. And if it's gonna be immunoglobulin G class of antibody alone present, alone, not with surface antigen. I've already told you, if it is with surface antigen IgG class of antibody, it is chronic hepatitis. This time, this could either be a low level carrier, as I explained in the previous slide, or it could be a remote infection. I've just written one of the permutation combinations here. And just to set the record straight, just to make you practice here, if this, both of these should be documented to say in practice, or let me say in multiple choice question, that this is acute Hep B. Without this, never comment upon whether it is acute version versus the chronic infection. And then I have already explained that E antigen will definitely add up to the chances of infectivity. The replication rate of the virus will dramatically grow up. So the same data has again been replicated before you, but I had to do this activity. I had to do the hard work of writing it and make you write it also, because then you will be able to remember this relatively better. And lastly, let us see what will be the treatment that you will be offering to any patient who has been diagnosed with chronic hepatitis B, because that is where the antivirals will come in. Now, for chronic hepatitis B, what's going to ultimately happen is that if he's not going to take treatment, then the stellate cells in the liver will come into the picture and they'll contribute to cirrhosis. First, it is compensated cirrhosis. Then subsequently, the patient will go into decompensated cirrhosis. The core difference, though there's a separate video, a long video on the cirrhosis and its complications, the fundamental difference between decompensation is development of portal hypertension. So you would be having bleeding varices, you would be having ascites in a patient. So assuming the fact that at this moment he is not even decompensated, he is just having signs of liver cell failure, like there could be pulmonary erythema, there could be parotid gland enlargement. Caput medusae develops relatively late, but then pulmonary erythema, spider nevi, they develop relatively early. So at the moment my patient has still not gone into decompensated, compensated cirrhosis will occur, then it would be decompensated, and finally fulminant hepatic failure, coagulopathy, bleeding will contribute to mortality of the patient. If the person is having chronic hepatitis B, then I would like to check for the following lab reports of the patient. I will be ordering a PCR. Let's look at the threshold in PCR in this particular case, because that will be one of the important aspects to be remembered from the questions perspective. So if you read a PCR that says, or a report of HBV DNA that shows, or it mentions that there is presence of at least 2 into 10 raised to power 4. Remember this value very carefully. I'm saying 20,000, but in MCQ, he's not going to write it 20,000. He's going to write it as 2 into 10 raised to power 4 international units of DNA per ml of blood. And along with this, he also mentions that the SGPT of the patient is double. Remember, I told you, in acute kidney injury, creatinine might show a doubling, or in MI, the troponin I values might be showing a doubling. So both of these two things should be written in the question for me to mention that I'll be initiating treatment for this chap. And what's the treatment? I can start this person either on entecavir or on tenofovir. Though any of the two can be prescribed, majority of books first mention tenofovir, so I will be using a 300 milligram dosage for this patient. This is to be taken on a regular basis, but for approximately 48 weeks. And if this person is going to be compliant, then the surface antigen will turn negative. The viral load from 20,000 will decrease to maybe 300, 400, and subsequently become even undetectable. I said from 20,000, which would be having more number of zeros, to only 200 viral copies present, and then maybe 20 viral copies present. So I'm decreasing the viral load. SGPT of the patient will also keep on coming back to normal. And whenever you are giving tenofovir, you are not only supposed to, check out the LFT of the patient, because we are after all talking about treatment of chronic hepatitis, but even a watch on KFT is to be taken when tenofovir is being given to the patient. because the virus was replicating aggressively. So E antigen report, if given positive, definitely tells you the fact that the damage is on. So if this is the kind of information given in a question, serological definition of chronic hepatitis B already told you, so I'm not written it. Surface antigen, IgG class of antibody to the core antigen, but along with this, the data in green, if it is given for chronic hepatitis B, you have to initiate treatment for the patient. Now, there could be a slight variation in the question, especially with respect to the data of cirrhosis, which is compensated. So just keep a watch on slight modifications that are made. You see, the question is saying the person of hepatitis B has developed compensated cirrhosis. E antigen is positive. I mean, after all, because the virus is replicating, that is why no, he has deteriorated. The virus is, he did not take treatment, he did not come to me in the initial phase. So that means that he is deteriorated into compensated phase. So E antigen is still replicating. The hepatitis B DNA of this patient was checked by PCR technique, and the report is showing 2 into 10 raised to power 3 international units of DNA per ml, and everything else is same. You are still having cytopathic damage, so SGPT is showing a doubling. You might be wondering, sir, for such a small thing you are highlighting and writing so much of data, but you see, in the exam, in pressure cooker situation, there is a possibility that you might miss out these figures. I want you to remember the thresholds for treatment. The thresholds for treatment for chronic hep is 20,000 international units, but for compensated cirrhosis, the threshold is kept lower. Why lower? Because damage is more extensive, no? You see, if damage is less, I'll keep a higher threshold. If the damage is more, I'll keep a lesser threshold. So when you are encountering or going through questions, there is a possibility that I taught you 2 into 10 raised to power 4, and the threshold given in the question might be 10 raised to power 3. Why? Because if the patient comes late to you, you have to keep a lower threshold. I will try to treat even at a lower viral load because damage is substantial in the patient, and after this is only decompensated cirrhosis, and if he goes into decompensated, that's definitely bad news, because portal hypertension, once it develops, the complications are so many. It's not only about managing ascites or a refractory ascites. That ascites can develop spontaneous bacterial peritonitis. The SBP can develop sepsis and development of septic shock, and then if it bleeds internally, because anyway the liver mass is critically reduced, there could be precipitation of hepatic encephalopathy. So managing a patient of decompensated cirrhosis is much more difficult. You spend so much of time and energy in a patient who, if had come to you earlier in the following stages, you would have been able to manage the patient more effectively. I hope that makes sufficient justification for why I invested time for something as simple as 20,000 versus 2,000 international units of DNA. This is, I would say, the last battle station before I would say you lose the game, because at this point of time, if intervention is not done, things are over from the perspective that it's going to be cost-wise very expensive for the patient to manage. And anyway, I mean, considering the fact that you are handling so many challenges, if you slip on even one, the complications would be fairly catastrophic for the patient. Now, once we have studied about hepatitis B, I will also mention about hepatitis A and E, which I think are more important from PSM perspective. But I want to clear before you the fact that if the question simply says what is the leading cause of development of acute viral hepatitis, then the answer should be given as hepatitis E. And I'm not saying it just from PSM perspective. Even Harrison is saying the statement that acute viral hepatitis is hepatitis E. Then is again some data which you can revise for hepatitis E. The leading cause of fulminant hepatic failure in pregnancy is hepatitis E. But if pregnancy word is not given in the MCQ, then if you read the table in Harrison, fulminant hepatic failure is given to be 20% for hepatitis delta, and you very well know patterns of infection of hepatitis delta. You could be having a co-infection, super infection. So the message is, especially with respect to co-infection, there could be 20% chances that person can go into fulminant hepatic failure. And yes, the Chinese were the first ones to develop vaccine for hepatitis E. When it comes to hepatitis A, it will be transmitted by fecal route, though both A and E are transmitted by the same thing. But do you have a fulminant hepatic failure with A and E? Then the answer is yes. Fulminant hepatic failure is seen with both. It's anywhere written, no, fulminant hepatic failure in hepatitis E is definitely seen. It can go up to as much as 0.1 to 1%, but in pregnancy will jump up to much higher. In fact, it can go up to as much as 30% in pregnancy. And when it comes to A, the incidence is still very much there. In fact, I wanted to remember fulminant hepatic failure can be seen with all. All of them can cause fulminant hepatic failure. Then they will say we do not have carriers in chronic hepatitis in, so we do not have carriers in hepatitis A and hepatitis E. In fact, let me just jot it down before you. Fulminant hepatic failure is going to be encountered in all of them. But when it comes to chronic hepatitis, I'm putting a crosshair to say it is not encountered with A and E. Though the data is given in the tables of PSM and microbiology, I do find people, messing up on it. So I just try to analyze the table before you by giving this information. FHF is present in all of them. We even have it in hepatitis A. Hepatitis A turns out to be more symptomatic in adults who have not had subclinical infection. Like an American comes to India and he's eating street food. Right, you see so many of these YouTubers, they come from foreign countries and they're eating Indian food and they have million views and stuff like that. They're making money actually by coming to India and eating Indian food, but they might fall sick because they've not been exposed to hepatitis A. So the antibodies that you'll be doing for this case would be IgM class of antibody to hepatitis A, as I've highlighted. And we do have a vaccine for hepatitis A which is recommended in children. In fact, most of the kids after 1 year of age can be given 2 dosages of the inactivated vaccine. This could be given at a gap of about 3 to 6 months. So like you can give one at 15 months, the second one can be given at 18 months or something a little after that. But the message is we do have vaccines available for hepatitis A, hepatitis B and hepatitis E, but we do not have the vaccine against hepatitis C, and that is the most dangerous one, because in majority of cases of hepatitis C, as I sensitized you in the earlier part of the discussion, there could be conversion to chronic hepatitis, to cirrhosis, and then the requirement for orthoptic liver transplantation. In majority of cases of A and E, the recovery will occur very, very fast. In fact, most patients will never come for a follow-up because you will just be giving conservative management. And yeah, as a matter of fact, prescribe high carbohydrate diet and low fat diet, because fat would anyway increase the nausea component. So prescribe a high carbohydrate diet for all of these patients. Standard findings in all patients of hepatitis could be icterus. Icterus could be present in the sclera because I sensitize you to the fact that the elastin component of the sclera will be having high affinity to binding to bilirubin, though in dark-skinned individuals, even the base of the tongue could be having this. So frenulum can also be checked. Spider angiomas are dilated cutaneous arterioles. These findings I've discussed in chronic hepatitis and subsequently cirrhosis video. But at this moment, I just want you to be remembering the fact that spider angioma, don't think that it is only a feature of alcoholic liver disease. It can be found in both acute as well as chronic liver disease. They are anyway found in alcoholic hepatitis. Spider angiomas in superior vena cava distribution on the neck of the patient, shoulder of the patient, but they can also be seen not only in acute hepatitis but even in acute and chronic liver disease. The liver span will become bigger, so you would be having a tender hepatomegaly, and subsequently if an acute hepatitis case progresses to chronic, albumin levels will begin to fall. Once the albumin levels will begin to fall, you will start having ascites, which can be picked up by shifting dullness. I've described SAG subsequently in the subsequent video, but here I'm just trying to summarize what are you gonna see in the patient. Once there is a progressive downhill course, once there is a cirrhosis which decompensates, you would be having encephalopathy, one of the early manifestations. However, if the question says what is the earliest manifestation of hepatic encephalopathy, your answer would be alteration in the sleep pattern of the patient. You can ask the patient to simply join some numbers. Like if I at the moment is putting up some numbers randomly on the piece of paper, I can obviously join 1 with 2, 2 with 3, 3 with 4, 4 with 5. Even if I'm very sleepy, even if a person has taken alcohol, he might be able to do this task. But a person of hepatic encephalopathy, the number or the trail making test will definitely fail. So we are demonstrating apraxia. Then you would be having caput medusae, which will be found around the umbilicus, and the blood flow will be away from the umbilicus. There would be widened pulse pressure, hyperpigmentation and lichenification, because pruritus is a big time problem in cholestatic jaundice that occurs in patients. Though if he specifically mentions about slate gray hyperpigmentation, then you have to take in consideration hemochromatosis as well. And lipid profile is mostly deranged in most patients of liver damage, so xanthomas and xanthellamas. I want you to remember that these findings, which are mentioned here grossly, can be seen in acute, then subsequently in chronic, and subsequently in cirrhosis. Though in the subsequent videos, what I've done is I have described the ones which are specific for a particular stage. Here I've tried to, in this particular slide, just give you an overview of how the findings will evolve in a patient and what could be triggers for hepatic encephalopathy. It could be simple thing like internal GI bleed. You see, let us take this to be representation of the gut. This is blood. So when the blood will flow down into the gut, what's going to happen is that this blood is a very good culture media. So it will help in multiplication of the flora in the gut. And flora of the gut, the bacteria are the source of ammonia. So you could be having bleeding precipitating encephalopathy. If you give too much of diuretics, then loss of water from the body will raise ammonia concentration. Repeat the fact once again. If you give diuretics too much, you are depleting water in the body. If you deplete water in the body, as a result of it, concentration of ammonia, concentration means ammonia divided by water in the body. If water is less, ammonia concentration will rise. So there can be dehydration, infection. Bacteria in the gut produce ammonia. If there is constipation, so that is why we give lactulose. No, you want a person with decompensated liver disease, encephalopathy to have 2 to 3 loose stools a day. The reason I want 2 to 3 loose motions daily is to clear out the bacterial flora so that the chances or development of encephalopathy can be reduced. And if there are usage of narcotics anyway, the encephalopathy component will increase. And as you will listen to the subsequent videos, you will notice all of these manifestations will once again come in, and there I'll be more descriptive than what I have been at the moment for the physical findings that can be seen with respect to liver disease. This slide per se is a broad, I would say, perspective that I've highlighted. Now comes the aspect of evaluation of liver function test in a patient. So for any acute liver decompensation, whether it is Wilson disease, hemochromatosis, whether it's going to be infective, you will always look at the following parameters. That is, either you will be having rise of SGPT, that is ALT, or you will be having predominant rise of alkaline phosphatase. If you are having a predominant rise of alkaline phosphatase, it always signifies obstructive jaundice in a patient. And along with that, gamma GGT, ALT values might also be elevated. But if you're having a predominantly ALT rise, it means the fact that this patient is having a hepatocellular or a hepatic pattern present. So one, laboratory reports should always be interpreted in the right way. I mean, if you look at conjugated bilirubin with alkaline phosphatase 4x OJ, so what tests will you write for the patient? You will write tests which can contribute to cholestasis like primary biliary cholangitis. That's a separate video in the discussion. So anti-mitochondrial antibody. I will also be checking out for the drug history in the patient, whatever is the drug intake, because they can also contribute to cholestatic jaundice. And then ultrasound, because the first investigation, if he says what is the first investigation for evaluation of obstructive jaundice, it is ultrasound, but then it will not be able to pick up mainly intrahepatic causes. Then even MRCP will be useful for imaging subsequently. Like when I describe primary sclerosing cholangitis, you see in primary sclerosing cholangitis what happens is that both extrahepatic and intrahepatic areas of the lungs are involved. So if you want to demonstrate the strictures in the extrahepatic component, because that is contributing to intrahepatic disease. See, the problem is there is fibrosis inside the liver. Why is it developing? Problem is in the biliary tract. So I can image the biliary tract by performing a MRCP in the patient. So the test that you write for obstructive jaundice will be different from the one you evaluate a hepatocellular jaundice, because when it's hepatocellular, you anyway need to check for first viruses, about which I've already told you that what should you write. You should write test for hepatitis A, test for hepatitis B, and test for hepatitis C. If the three are negative, it could be non-A, non-B, non-C, that is hepatitis E also, which is the #1 cause of acute viral hepatitis. Conservative management, high carbohydrate diet, admit if there is dehydration and correct the dehydration, treat the vomiting component or the nausea component, the patient would do fine. However, there could definitely be causes which could be beyond hepatotrophic. So I'll be doing antinuclear antibody and SMA. These would mainly be used to pick up autoimmune hepatitis. This is again a separate video that I have recorded, and you will notice it as you scroll down in the app for the liver topic. And then I'll also check for possible metabolic causes. So ceruloplasmin, especially if there's a family history. Otherwise, believe me, ceruloplasmin alone is a very useless test. Only with a positive family history, like a sibling died with liver disease and neurological manifestation. So I'll do a ceruloplasmin, check for history of alcohol. And I told you, occult alcoholism, I can be doing a gamma GGT in the patient. Drug intake is anyway important. So you can very well see that interpretation of LFT is better understood when you read about the causes which are responsible for it. So I would like you to come back to this particular slide once again when you've listened to the topics that I've mentioned here. You can listen to primary biliary cirrhosis, primary biliary cholangitis, then autoimmune hepatitis and other aspects that I've discussed. And then when you look at these patterns that I've written before you, they'll definitely make sense. I want to highlight once again, gamma GGT is very non-specific. Do not answer it for alcoholic hepatitis. The word is hepatitis. That means damage is there. For occult alcoholism, gamma GGT is fine. I definitely agree to that. But the question in the exam was not occult alcoholism. It specifically mentioned alcoholic hepatitis. That is SGOT that is to be answered. SGOT, SGPT ratio more than 3:1. 3:1 is strongly specific for diagnosis of alcoholic hepatitis in a patient. And in fact, we also have a Madry's discriminant score that you will read in alcoholic hepatitis video subsequently. And you would be much more comfortable coming back to this slide. And this also explains the reason that instead of starting with this slide, because when you first time read liver topic and suddenly you're bombarded with so many diseases, it really does not make sense. So first read the disease, then come back to this, and it will definitely be much more productive for you. So these are the details that I want you to remember for the topic. Keep hammering, guys, keep the focus on, and I'm very sure you'll come out with flying colors.